Welcome everyone to COVID-19 Pulmonary Evaluation and Management. It's a privilege today to have Dr. Susan Garwood joining us. Susan is a practicing pulmonologist at Centennial Medical Center in Nashville, Tennessee, and also one of HCA Healthcare's national physician leaders. Susan, we wanted to pick your brain a little bit today about pulmonary manifestations of COVID-19. Tell us a little bit about what you're seeing.
Thanks so much for the opportunity, Steve. So, agree, this has predominantly been a pulmonary-driven disease. So when we think about the way that these patients have been presenting, classically the beginning symptoms have been dyspnea. So shortness of breath, usually around 5 to 8 days into the syndrome. We see about 20% of those will move on to ARDS-type symptoms, and about 5% of the overall population ends up requiring mechanical ventilation. The pulmonary symptoms can be very much like those that you see with other viral illnesses with associated fever, which is present in the universal population. Interestingly, only about 50% of the Chinese population had fever the first day. But fever, fatigue, and a dry cough are the predominant symptoms, and pulmonary correlates with radiography we'll go over in just a moment. But there's some classic findings that we see there.
I mean, obviously this is an infectious disease, but those that are clinical, is it the overwhelming majority that have some pulmonary manifestations?
Absolutely. So 80% of people have some type of mild symptoms, and usually can be as simple as a common cold symptom, cough or rhinorrhea. So 80% of our patients have very mild symptoms, and another 20% have symptoms significant enough to require hospitalization, most significantly low oxygen level and pneumonia.
I know it's a moving target, but many patients can be asymptomatic as well. Is that also the case for those that may or may not have asymptomatic pulmonary findings and not know it?
So asymptomatic patients usually just have a dry cough and a little bit of dyspnea, not enough to affect their daily life. And so we consider those that really have no pneumonia or only mild symptoms that don't affect their quality of life to be in the mild category. And you're correct, that's only 80% of our population that has that.
You know, the next question really relates a little bit to use of imaging, whether it be an examination or stethoscope or advanced things like a chest x-ray or CT, etc. What are your thoughts on which imaging modalities make sense? And I guess even more complicated because some of these folks are either actively infected or suspected of being actively infected.
Yeah, this is a great question, and one I think that we all are struggling with on how to make the initial evaluation. So what I would say is there's not one imaging modality that will rule in or rule out COVID. So we need to be careful about the way that we're utilizing these. If we look at the Chinese data, specifically trying to answer the question on is chest x-ray versus CT most appropriate, what we see is that the chest x-ray findings can be quite classic. And so you traditionally see ground glass changes on both sides, peripheral and lower lobe in the majority of these patients. If you have classic scenarios such as that in a clinical presentation that fits, CT is not warranted. Again, the exposure, like you talked about, is having to transport a patient through the hospital, through an elevator system, into a radiology department that now has to be deep cleaned. So the resources and exposure risk, when it might not change your clinical outcome or your clinical management, really seems to be the question. We don't want to forget that a CT scan in the appropriate patient is always the right thing to do. If you have a classic patient with signs of PE, again, we want to make sure we're imaging in the right way. We still need to consider business as usual, and there are a large number of patients who enter our ERs every day where CT is appropriate. The main issue is if you have a classic chest x-ray finding and some lab findings, again, chest x-ray alone is considered to be gold standard.
You know, how can physicians get fooled? Are there masqueraders that maybe, you know, I have a patient and they've got some cough and maybe they even have a fever, and unfortunately nowadays that raises the suspicion of COVID-19 in everyone. On exam or on chest x-ray, maybe we'll limit it to those two, are there things that this is going to mimic or fool me and get me down the wrong path?
Yeah, I think that the main thing to recognize is that if we have people who come in, we have a large population in the country who have COPD. So when a patient comes in with history of COPD, wheezing, very tight lung sounds, we have to assume that that is COPD exacerbation and consider standard treatment, including IV steroids. If we listen to the patients, the majority of the time in COVID patients, they actually have quiet lungs. If anything, they may have interstitial sounds, which can sound like Velcro crackles or some fine ralls. But in these patients, the stethoscope exam is not nearly as helpful as the overall labs plus imaging plus the patient history.
Right. And then, and help me navigate from chest X-ray rather to CT. What types of patients would I be more likely to say, I know I shouldn't do a CT in everyone, but this is someone that is getting me a little bit extra concerned?
Yeah, so I think the initial things are if patients' clinical picture, when they present, the majority of these patients can have white counts that are high or low. In COVID-19 patients, they tend to have lymphopenia. They tend to have elevated CRPs, elevated D-dimers, elevated LDH and liver function tests. So if you have those findings along with a chest X-ray that fits, then a CT would not be appropriate. The difficulty comes when you have those alternate diagnoses, or when you may have imaging on chest X-ray that might show adenopathy or an effusion or cavitation. Those things are seen in less than 5% of patients on chest X-ray imaging by the Wuhan study. So if you see those findings, it definitely should have you really move to CT for further evaluation. Procalcitonin is another. A high procalcitonin level when patients come in can indicate bacterial pneumonia or an acute bacterial process, or it may mean that this is a COVID patient that's very sick moving to the ICU. So it really is a care continuum where we have to constantly evaluate how the patient is acting in combination with lab findings as well.
You know, I can only imagine what your practice looks like, patients that have underlying chronic lung disease and underlying cardiopulmonary disease, or diseases, plural, more likely. And I'm struck with what the profile appears to be looking like for patients that are at higher than average risk, and it seems to be those that are into their 50s, 60s, 70s, and those with underlying diseases. Tell me what you think about your patient population. I think you mentioned it a little bit about COPD, emphysema, chronic bronchitis, and how do you manage that patient population, understanding that this time of year or any time of year, they're probably at accentuated risk?
Right. I think we definitely, like we talked about before, have to be very aware of our active disease processes. My patients with COPD, interstitial lung disease, and underlying lung cancer are going to be admitted with hypoxemic complications and fever on an average day. So what we have to do is be very diligent about looking at these extra clues about how to manage. One of the difficult things is trying to decide on who to do procedures on, specifically those with lung cancer or those who may not be acting normally. And so we have to really use thought about who we're going to expose to the hospital and what resources we may be using to work up these patients. But indeed, the group that you mentioned, specifically older people, people with hypertension, people with cardiovascular disease, and those who are immunosuppressed are going to be ones who have higher morbidity and mortality. Those with complex medical histories are going to take a team approach to make sure that our management algorithms aren't completely overridden with COVID, that we have to consider traditional exacerbations of underlying disease.
You know, that's a perfect pivot point to our next question, which is really, is there a role for bronchoscopy in some of these patients? And I tend to suspect that the answer to that is, well, maybe, depending on the patient. But tell us a little bit about when you would consider bronchoscopy in a given patient, and what the risks and benefits of that procedure might be.
Absolutely. I think we've certainly learned from our Chinese and Italian colleagues. Initially, when these patients presented, there was a large amount of patients who were getting CT imaging and bronchoscopy with BAL. So we tried to look at that data, and again, the ultimate question to me when we're talking about treatment algorithms is, how will it affect my patient care? Will it change my treatment decision-making, and what's the risk involved both for the patient and for the provider? So like you said, bronchoscopy will have a role in some people. The initial question is it the right test for initial diagnosis over a nasopharyngeal swab? The CDC has said no, even though we know that the sensitivity appears to be higher with bronchoscopy, the risk associated with aerosolizing every patient that came through with COVID suspicion would be too much for our healthcare system. Nasopharyngeal swab is considered the gold standard. However, if you have a person under interest whose test comes back negative, the next step per the CDC and World Health Organization is to proceed with a multi-sample, repeated nasopharyngeal or oropharyngeal, and consider bronchoscopy. We can't afford to miss this, but we don't want to use bronchoscopy as the initial diagnostic procedure. These patients are going to have very sticky mucus is the other thing that's clearly come that's shown that they may have mucus plugs. Bronchoscopy is always indicated if you have a suspicion for an obstructing lesion, if you have a mucus plug, if you think you have secondary bacterial or superinfection on top of this, again, or hemoptysis for any reason that's not clear of its origin. So we have to continue to use our guidelines for when bronchoscopy is indicated, but take careful attention to not use it too exuberantly in the initial diagnostic phase here.
You know, that really does move us to our next question, which is we're so used to talking about the risk-benefit to a patient that now we're really talking, even on top of that, about the risk-benefit to the healthcare system. This is a disease that, to a great extent, is shared or spread through pulmonary secretions, et cetera, as you mentioned. What are the added precautions that need to be taken, whether or not it's a patient in the bronchoscopy lab or a patient going to a CT scanner, and how do we make sure that in doing the right test we utilize our PPE equipment effectively and also minimize the risk to teams and teams of folks that are caring for patients?
Yeah, I think this is of utmost importance, like you said, both to caregivers and patients alike. I think I'll take that in a two-part question, one specifically related to aerosolizing procedures. So if you were involved in an aerosolizing procedure such as intubation, bronchoscopy, non-invasive ventilation, or doing nebulizing medication, the recommendation is an N95 mask or equivalent or PAPR. So both of those things may or may not be in short supply. The trickier area comes in those who are not doing aerosolizing procedures, such as transporting a patient or evaluating a patient in the room. Droplet precautions or simple mask is recommended. I think this is continuing to be a moving target, specifically covering your hair. We definitely know that goggles, face mask, gown, gloves, and a simple mask at minimum, and an N95 if our supply chain allows, likely is going to be standard recommendation, but currently N95 or equivalent for aerosolizing procedures, and then standard PPE plus a simple mask for droplet precaution.
You know, the next question really relates to patients that become symptomatic. From there, those that need to go to the hospital. From there, those that need to be hospitalized. And of course, the final pathway is those that need intensive care unit management. And so as we look at the critical care of these patients, maybe walk us through your thoughts on which of our patients at a time where ICU beds and hospital beds are most likely going to be in short supply due to surge projections. How would you assess whether or not someone needs to go to the ICU? What can they get in the ICU that differentiates that bed? And then how best can we stabilize them from a pulmonary standpoint, a cardiac standpoint, and get them on the road to recovery?
Yeah, and I think, again, it's a great question and one that continues to evolve as we have more experience here in the United States. But things that should trigger you to move that patient forward to the ICU is that you can move, as I mentioned before, from dyspnea to ARDS very quickly. So when you begin to see escalating hypoxemia and you get to more than 4 to 6 liters, you should be thinking of moving to the ICU and moving to elective intubation. That has been shown to have better outcomes. High-flow nasal cannula definitely needs to be employed early on, not a simple cannula. And prone ventilation has been helpful, not only in intubated patients, but those who are on high-flow cannula as well, to help prevent them moving forward to intubation. Again, we want to deliver any meter-dose inhalers not via nebulization, but to use the MDI to try to prevent these patients from moving forward. But there is a small subset of anywhere between 10 and 15% that will require critical care services. and those include hemodynamic evaluation and ultimately 5% that have shock, multi-system organ failure that might require dialysis, advanced hypoxemia that might require ECMO, and certainly the 5%, the vast majority of those percentage are on a ventilator. So we need to have services capable and staffing capable to manage that type of demographic. And the amount of services, I can tell you, our number one goal here should be standard, excellent critical care medicine. That is what's going to save lives. And having a very clear critical care pathway to get these patients set up immediately with intubation, OG tube, arterial line, and cardiovascular line, because the needle can move so quickly. We want to be prepared for things like cardiovascular collapse, signs of vasodilatory shock, myocarditis symptoms, and specific any types of renal failure and volume dyscrasias.
Well, Susan, thank you so much. Thank you for your clinical leadership and your sharing your time and expertise with us. I'd like to move on to final commentary. I know that this will be one of many conversations, and I'm confident that we'd love to get you back at a future date to talk about a deeper dive into some of these areas. But you know, we have physicians that are in primary care. We have physicians that are specialists, but this is a bit foreign to them. We have emergency medicine colleagues and certainly intensivists, pulmonologists, and even non-physician providers that help contribute to the care of these patients. Give us some final words of wisdom that we might share, and then with our thanks, we'll leave everything else for the next time.
Yeah, absolutely. I just want to start by saying I'm so grateful for the opportunity, and like you listed, a very long list of people who are involved in the care, starting from the outpatient urgent care centers and our primary care physicians. We all have a role in this disease. Number one role being flattening the curve. Again, we need to really continue to focus on social distancing. But for those specifically in healthcare, we are grateful for your patience with us, grateful for your triaging patients appropriately, but this is going to take a group effort. It will challenge us in ways that we have not seen before, call upon some of us to dust off rusty skills we may have previously put on a shelf, but most of all, this is really going to show what the goal here at HCA is, which mission first is taking care of these patients. And so we're grateful to each of you for your contributions already and in the future, and let us know how we can be of help.
Well, great, Susan. Thank you so much for sharing your expertise with us. To all of you, feel free to reach out to us or reach out to others in your local environments for advice, for help, for guidance in these areas. And thanks for all you do for HCA Healthcare.